All right, welcome to this explainer on Duchenne muscular dystrophy, or DMD. Today, we're taking those dense, textbook clinical notes and translating them into a logical, step-by-step pathway. We're going to go all the way from that very first bit of diagnostic detective work right through to building a lifelong partnership with your patient. Because every single step we cover today, from the first question you ask to the final piece of advice you give, is absolutely critical for building a rock-solid management plan for these kids.
Okay, here's our clinical roadmap. We'll flow right from taking the patient history into key physical exam steps, diagnostic investigations, medical treatments, and finally the multidisciplinary team and advice. Let's jump right into step 1.
Part 1. Taking the patient history. We're starting our detective work right here in the consultation room.
So, you gotta ask yourself, what's actually bringing this patient in today? Keep in mind, DMD typically shows up in young boys, usually hitting between 2 and 5 years of age. So you're really looking out for things like delayed motor milestones. Maybe they're falling down a lot, or parents might mention their child is suddenly having a tough time climbing the stairs.
Now, distilling a massive systems review in actionable questions is super important here. When you're building a management plan, you simply can't afford to miss secondary complications. So think CNS. Are there signs of hypotonia or limb weakness? Musculoskeletal, any frequent falling or bone deformities? You absolutely have to ask about the chest too. We're talking repeated infections or fast breathing. Don't forget the GI tract, things like a larger tummy size or constipation. And finally, cardiovascular red flags like a racing heartbeat or syncope. Nailing this comprehensive history means you catch the whole picture early on.
But you can't just stop at those immediate symptoms, right? You have to dig into the historical context. How was fetal and neonatal life? Were there decreased fetal kicks? Did they have any NICU admissions or abnormal hip screenings? You also need to grab a full gross motor and cognitive developmental history. And this is huge. Check the family history for any myopathies, specifically on the mother's side, since DMD is an X-linked recessive disorder. Oh, and definitely note if the kid is already using special shoes or has postural abnormalities. Getting a baseline on their mobility aids early on is a total game changer for shaping your long-term management plan.
Okay, moving on to part 2, key physical examination steps. This is where your hands-on clinical skills really validate those initial suspicions. Take a really close look at the hallmark Gower sign here. Because these kids have severe proximal muscle weakness in their pelvic and shoulder girdles, they literally have to use their hands to walk up their own legs just to stand up from sitting. It's a very distinct movement. You'll also probably spot calf pseudohypertrophy. The calves look enlarged, but actually, scratch that. It's not muscle growth. That bulk is actually just fat and scar tissue replacing the healthy muscle.
So your hands-on exam needs to be highly targeted and systematic. You're doing a full neurological exam, checking tone, power, reflexes, and the Babinski sign. And definitely keep a keen eye out during the gait assessment. You're looking for a waddling gait, clumsiness, or toe walking, which is sometimes tied to pes tavis. Inspect their back for a pronounced lumbar lordosis, and always check for limb length discrepancies and muscle contractures. Why? Because those findings directly dictate your physiotherapy management plan later on.
Now, this is an absolutely crucial point. Do not let those dramatic musculoskeletal findings distract you from the heart and the lungs. You absolutely must examine the chest to understand the physical effect that lumbar lordosis has on pulmonary function and spirometry. Plus, you need to screen for early cardiac issues. Ultimately, a patient's cardiopulmonary status is going to be the absolute most critical factor in their long-term management. Right, let's move into part 3, investigations for diagnosis. Once your history and physical point to DMD, it's time to confirm it.
Your diagnostic escalation starts with a simple lab draw. You're looking for markedly elevated creatine kinase or CK levels, and often you'll see elevated AST and ALT right alongside it. Step 2 is the gold standard, genetic testing. You want to confirm a mutation in the dystrophin gene on the X chromosome. Fun fact here, dystrophin is actually the longest known human gene, which unfortunately makes it a massive target for these spontaneous mutations. Finally, step 3. You only reserve a muscle biopsy to check for absent dystrophin if it's absolutely needed, like if the genetic testing comes back inconclusive.
But before you completely lock in that diagnosis, you have to distinguish DMD from other differentials. The big one here is Becker muscular dystrophy. So while DMD has an early onset, severe progression, and completely absent dystrophin, Becker is a milder variant and has a later onset, a slower progression, and there's actually some functional dystrophin production. Differentiating the two is vital. It literally completely alters the timeline of your management plan, especially when it comes to figuring out exactly when you'll need to introduce mobility aids and respiratory support.
Which brings us to Part 4, medical treatments. Diagnosis confirmed, we now shift from detective mode into proactive medical management.
Your core medical tools are highly targeted. First up, corticosteroids, like prednisone or deflazacort. These are your mainline defense to slow down motor deterioration and protect pulmonary function. Then you have targeted gene therapies, like atalurin. This can be a total game changer specifically for nonsense mutations, provided the patient is still walking. And, it's worth keeping in mind that routine management typically doesn't even require hospital admission, as long as the patient remains clinically stable.
Understanding the timeline of this progressive degeneration is exactly how you anticipate when your management plan needs to pivot. Look at this progression. You go from delayed walking at ages 2 to 5 to a waddling gait and trouble on stairs by ages 5 to 10. Crucially, you have to proactively prepare the family for the loss of ambulation and wheelchair dependence, which usually hits between ages 10 and 12. And as they transition into their teenage years and adulthood, your management plan has to heavily shift toward addressing severe cardiac and respiratory complications.
And that leads perfectly into Part 5, multidisciplinary team and advice. Managing DMD over this timeline is never a solo endeavor. Because DMD affects pretty much every body system, you have to strategically map out a vast, multidisciplinary team to tackle specific clinical risks. A cardiologist is vital to manage the high risk of dilated cardiomyopathy and arrhythmias. A pulmonologist is strictly focused on respiratory failure, closely monitoring PFTs and spirometry. Your physiotherapist and orthopedic team, they're going to tackle stretching, preventing contractures, and managing scoliosis. Meanwhile, the neurologist and gene therapist stay focused on overarching disease modification.
And we can't forget the essential allied health support. Your management plan just isn't complete without them. We're talking occupational therapists, speech and language therapists, and folks handling ongoing child development assessments. These are absolute necessities. You also have to include rigorous nutritional support. Honestly, these professionals are the ones who are really going to maintain the patient's daily quality of life as the disease progresses.
But perhaps the most impactful intervention you can provide as a clinician doesn't come in a pill bottle. It's delivering robust family education and ongoing genetic counseling. Helping the parents and the patient truly understand and navigate this progressive reality, that is the absolute cornerstone of effective, compassionate care.
Finally, ensure your practical advice covers everyday safety measures. These patients need to wear medical bracelets at all times, no exceptions. You also have to emphasize the absolute necessity of rigorous respiratory care and keeping vaccinations strictly up to date. This simple step is so vital to prevent the recurrent chest infections that constantly plague these patients and accelerate their respiratory decline.
So as we wrap up this explainer, I want to leave you with a provocative thought. How will you seamlessly blend this rigorous diagnostic protocol with the compassionate, multidisciplinary care required in your own practice? The path from spotting that very first Gowers sign all the way to managing long-term cardiopulmonary health is incredibly complex. But with a structured management plan, you can truly make a profound difference. Thanks for joining me on this clinical journey.